Welcome to Week 7, Part B. We're shifting gears from the technical details of database security to a broader view of the healthcare data landscape. For the last 7 weeks, we've been working with Postgres, a relational database that handles structured data beautifully, but the healthcare world generates far more data than that which fits neatly into rows and columns. This section introduces big data, what it is, why healthcare is one of the biggest producers, and how it connects to everything that you have learned so far. You'll find big data defined in every textbook as data sets so large or complex that traditional data processing tools cannot handle them. The term first emerged in the early 2000s and became a healthcare buzzword around a decade ago. But the definition alone is not very helpful. The real question is, when does a lot of data become big data? Our X-Health database has about 135,000 records, so it fits comfortably in a few megabytes. Postgres handles it without breaking a sweat. But a major health system might have hundreds or millions of records and terabytes of imaging data and continuous streams from wearable devices. At that scale, the tools and approaches we've been using start to fall apart. That's the threshold where big data thinking becomes necessary. It's not just about size, it's also about the characteristics that make data fundamentally different to work with. There are the three V's framework. Sometimes it's 5 V's. But the 3 big V's are the volume, velocity, and variety. Volume refers to the sheer scale of the data. Velocity refers to the speed at which the data is generated and needs to be processed. And variety refers to the diversity of data types and data formats. Some frameworks extend this to 5 or even 7 V's, adding veracity, which is about data quality and trustworthiness, and value, which is about extracting actionable insights. But for our purposes, the first 3 V's give you a solid conceptual foundation. So let's look at each one through a healthcare lens. Volume in healthcare is staggering. A single patient generates roughly 80 megabytes of data per year just in EHR records. Well, that sounds manageable enough until you consider that a 500-bed hospital, when you include imaging, genomic data, and patient monitoring, can generate around 50 petabytes per year. For context, our X-Health database with its 135,000 records fits in a few megabytes. So a real hospital system deals with millions of times more data. Globally, healthcare data is estimated over 30 exabytes and continues to grow at roughly a third or 36% each year. So volume alone demands storage, and processing capabilities go far beyond a single Postgres server. And that's where distributed systems and cloud infrastructures become essential. Let's talk about velocity in healthcare. Velocity is about speed. In an ICU, bedside monitors generate vital sign readings every second. A patient wearing a continuous glucose monitor produces about 288 glucose readings every day. Wearable devices like smartwatches stream heart rate, oxygen saturation, and activity data 24/7. During the COVID pandemic, real-time case tracking dashboards required data updates in sub-minute intervals. Postgres is excellent for batch queries and transactional workloads, but it was not designed for high-velocity streaming data. Processing thousands of data points per second from thousands of patients simultaneously requires different tools, like Apache's Kafka for stream ingestion and Apache Spark for real-time processing. Variety. Variety is perhaps the most relevant V for health informatics professionals. We've been working exclusively with structured data in this course, tables with defined columns, data types, and relationships. but roughly 80% of healthcare data is unstructured or semi-structured. Structured data includes what we know, demographics, diagnoses, lab results, all stored in SQL tables. Semi-structured data includes FHIR resources in JSON formats, HL7 messages, and XML documents. Unstructured data includes clinical notes, often written in free text formats, and medical images like X-rays, CAT scans, and MRIs, audio recordings from dictations, and even video from telemedicine sessions. To get a complete picture of a patient, you need to work with all these data types together, integrated. That requires databases and tools that go far beyond traditional relational database models. So how do relational databases compare to the big data systems? This is not an either-or question. Postgres and similar relational databases are excellent for structured transactional data where ACID compliance matters. You want your EHR transactions, your billing records, and your medication orders handled with strict consistency and integrity. Big data tools are designed for distributed storage and parallel processing across clusters of machines. They handle terabytes to petabytes of mixed data types. Most hospitals use both. The EHR system runs on a relational database for the day-to-day operations, and a big data platform handles analytics, imaging archives, and research workloads. The key insight for your career is these are complementary technologies, not competitors. If you're going to look at a big data technology stack, you would see several layers. At the storage layer, it seems like Hadoop HDFS or Amazon S3 and Azure Data Lake. They store massive volumes of raw data. But at the processing layer, Apache Spark and MapReduce enable parallel computation across distributed clusters. For streaming data, Apache Kafka and Apache Flink handle real-time ingestion. And for querying, tools like Presto, Apache Hive, and Google BigQuery let you run SQL-like queries on big data. You don't need to learn the intricacies of each of these systems. You just need some exposure. You don't need to memorize these tools' names. What matters is understanding why they exist, because different data challenges require different tools. No single system can handle everything. Two terms you will encounter frequently enough are data lake and data warehouse, so you should become familiar with those terms. A data lake stores raw data in any format, with schema applied only when you read the data. This is called a schema on read. It's flexible and great for exploratory analytics, but can become a data swamp without governance. A data warehouse stores cleaned, structured data with a predefined schema. This is schema on write. It is more rigid, but ensures data quality and consistency. So the current trend in healthcare is toward a lake house architecture that combines both approaches. Store raw data in a lake and curate high-quality data sets in a warehouse layer on top. This gives you the flexibility to explore and the reliability to report. One of the most impactful applications of big data in healthcare is population health analytics. This means analyzing data across entire patient populations to identify trends, risk factors, and opportunities for intervention. For example, which zip codes in our service area have the highest rates of uncontrolled diabetes? Answering that question requires combining EHR data with claims data, census data, and social determinants of health data. It requires aggregating across thousands or millions of patients. This connects directly to what we learned in week 6 with aggregate functions like count, average, group by, and halving. These are the SQL building blocks of population health. Big data tools scale those same analytic patterns to populations of millions. Genomics represents one of the most data-intensive applications in all of healthcare. Remember, a single human genome generates approximately 200 gigabytes of raw sequence data. When you're running genome-wide association studies across millions of patients to identify genetic markers for disease risk or drug response, the data volumes are enormous. So pharmacogenomics, which matches drug therapy to a patient's genetic profile, is particularly relevant. For those of you with some pharmacy background, you might know about the CYP450 enzyme and how genetic variations affect drug metabolism. Big data and AI are making it possible to analyze these variations across populations to personalize patient prescriptions. This is the promise of precision medicine, and it depends entirely on the ability to store, process, and analyze genetic data at scale. Medical imaging is where healthcare intersects most directly with artificial intelligence. AI models for radiology are trained on millions of correctly labeled known images, X-rays, CAT scans, and MRIs. Similarly, digital pathology involves scanning tissue slides at an incredibly high resolution for cancer detection. All of this requires massive storage and GPU accelerated processing. It's worth noting that over 950 of the FDA's 1,250 authorized AI-enabled medical devices are in the radiology and imaging space. So that's nearly 80%. This is not a future trend, it's happening now. The data infrastructure behind these systems is a classic big data challenge. High volume, high variety of image formats, and high velocity when processing scans in real time. What about wearables and remote patient monitoring? They generate a flood of continuous health data. A single patient with a continuous glucose monitor produces about 288 glucose readings every day. But an Apple Watch records heart rate and oxygen saturation and activity levels and even sleep data 24/7 around the clock. At a population health scale, millions of patients wearing some of these devices generate billions of data points every day. Use cases include early detection of atrial fibrillation or fall detection in elderly patients and sleep apnea screening. The challenge is not just storing the data, but processing it in near real time to generate actionable alerts. For example, if a patient's heart rhythm becomes irregular at 3 o'clock in the morning, the system needs to detect it and notify somebody within seconds, not hours later. Another area of interest is the social determinants of health, SDOH. It's a critically important dimension of big data in healthcare. Social determinants of health are the non-clinical factors that affect health outcomes, such as housing stability, food security, transportation access, income levels, access to education, and neighborhood safety. Research increasingly shows that your zip code is a stronger predictor of your health outcomes than your genetic code. So modern big data platforms are integrating social determinant of health data into population health models alongside traditional clinical data. And this is reflected in the fact that SDOH is now a data class in the US CDI version 3, which we covered a couple weeks ago. So the ability to combine clinical data from EHRs with the newer SDOH data from community sources is one of the most powerful applications of big data in healthcare today. HIDIS, which as you know stands for the Healthcare Effectiveness Data and Information Set, is one of the most widely used quality measurement frameworks in American healthcare. HIDIS measures require aggregating data across thousands of patients to calculate quality metrics. For example, what percentage of our diabetic patients had a hemoglobin A1C test in the past year? And what percentage had hemoglobin A1C levels below 9%, indicating diabetic control? This is exactly the type of aggregate query that we practiced back in week 6, using the group by and having clauses. And the difference is scale. A single clinic might not run these queries on but a few thousand patients. A national health plan needs to run them across millions of members, pulling data from hundreds of different source systems. That's when it becomes a big data problem. Let's put the big data conversation into market context. The global big data in healthcare market is valued at roughly $33 to $92 billion last year, depending on which analyst you reference. That range reflects different methodologies. Some focus narrowly on analytics platforms, while others include infrastructure, services, and AI tools. But this year, in 2026, projections climbed to 40 to 87 billion, and by the end of the decade, we're looking at 200 to 500 billion dollars. If you look at the compound annual rate of growth, it's sitting at 20%. What drives this? Well, it's the convergence of several forces that we've discussed. The explosion of EHR data, but also wearables generating continuous data streams, and genomics producing petabytes per study, and the shift towards value-based care models that require analytics to measure outcomes. Real-world evidence, which we call RWE, is becoming increasingly critical for regulatory submissions and post-market surveillance. Cloud infrastructure has lowered the barrier to entry, so even mid-sized health systems can now deploy big data platforms. These are not future projections. This is the landscape right now. Here are the applications that are gaining real traction beyond the traditional big data uses that we've already talked about. First, drug discovery and real-world data. Big data is accelerating every stage of the pharmacologic pipeline, identifying targets, designing clinical trials, and post-market surveillance. But the big shift this year is emphasis on data quality over quantity. Having petabytes of messy data is far less valuable than having clean, interoperable research-grade datasets that can actually support regulatory submissions to the FDA. Partnerships like the NVIDIA Eli Lilly AI labs are a concrete example of how technology companies and pharmaceutical companies are joining forces to leverage big data for faster drug development. Second, operational and financial analytics. This is where big data meets the business side of healthcare. Revenue cycle management, workforce planning, supply chain optimization, and claims processing are all being transformed. Ambient AI, which is AI that passively captures and processes data during a clinical encounter, is reducing the administrative burden that burns out clinicians. Predictive tools forecast patient demand so hospitals can staff appropriately. And third is federated learning. This is privacy-preserving approach where machine learning models are trained locally at each institution, and only the model parameters, not the patient data, are shared across sites. This addresses one of the biggest barriers to big data in healthcare, privacy regulations like HIPAA and GDPR. Federated learning lets the benefit of multi-site collaboration without ever centralizing sensitive patient data. So what's the key takeaway? The shift from volume to quality. Having more data is not automatically better. Having the right data in interoperable formats with research-grade provenance is what matters today. Let's look at the broader 2026 trend landscape, drawing from sources as diverse as Deloitte's Global Healthcare Outlook, or JP Morgan's Healthcare Conference, or Forbes, or Meritiv's industry reports. The headline statistic is that over 71% of hospitals now use AI in some capacity. That sounds impressive, but the reality is nuanced. Many of these implementations are pilot projects, limited in scope, and not yet delivering measurable return on investment at enterprise scale. So the big theme for 2026 is the synergy between big data and artificial intelligence. Big data provides the raw material, the fuel, for generative and agentic AI applications in diagnostics, clinical documentation, and operational workflows. But as adoption surges, the conversation is shifting from can we deploy AI to should we, and how do we govern it? Explainability, equity, and return on investment are now front and center in the discussion. On the interoperability front, FHIR standards are becoming the lingua franca for health data exchange, and federated learning frameworks are providing a technical solution to the privacy concerns. Real-time and multimodal data integration is enabling hybrid care models where in-person and virtual care blend seamlessly, powered by continuous data streams from Internet of Things devices and wearables. But the challenges are very real. Data quality remains the fundamental bottleneck. Algorithmic bias can amplify health disparities if the training data is not fully representative. The sheer velocity and volume of healthcare data demands tools like Apache Spark for distributed processing. Cybersecurity threats are escalating as more data moves to the cloud platforms, and fragmented regulations across states and countries slow the enterprise-wide scaling. The emphasis on clinician-in-the-loop validation is critical. AI should augment clinical judgment, not replace it. Evidence-based validation is what separates a promising pilot from a trusted clinical tool. So, the bottom line is simple for your careers. Understand these trends. It's essential because you will be the professionals bridging the gap between big data technology and clinical reality. We just convened the 7th National Big Data and Health Science Conference this past week right here in Columbia. And if you see on that picture there, I'm the second from the left. And it was an excellent conference, well attended, and I'm going to give you some feedback from some of the experiences that we had. No discussion of big data would be complete without acknowledging the challenges that we often gloss over, specifically in vendor presentations. Data silos remain the #1 obstacle. Most hospital data is still trapped in disconnected systems that are unable to talk to each other. Data quality is a persistent issue because unclean data produces unreliable analytics, and healthcare data is notoriously messy. Privacy at scale is a growing concern because the more data points you combine, the easier it becomes to re-identify supposedly de-identified patients. And the cost of building and maintaining big data infrastructure is substantial, and many smaller health systems cannot afford it. And perhaps most critically, there's a talent gap. Health systems need professionals who understand both healthcare and data science, data engineering. There are not nearly enough of them. That's your opportunity. Now here's something very important that I want you to take away from this course. SQL is not going away. In fact, SQL is the universal language of data. Even the big data tools often use it. For example, Apache Spark has Spark SQL. Google's BigQuery is queried with SQL statements. Amazon's Athena uses SQL. Presto uses SQL. The fundamentals you learned in weeks 1 through 6, how to design schemas, write queries, join tables, aggregate data, and optimized performance transfer directly to the big data platforms. So most healthcare analytics projects start with a SQL query on structured EHR data. Big data tools are for when you outgrow what a single Postgres server can handle, or when you need to work with unstructured data at scale. Your SQL skills are not just relevant, they're the foundation for your data analytic work. A healthcare data pipeline typically flows from source systems through transformation into analytics. Source systems include electronic health records and lab information systems, imaging archives, and even wearable devices. Data is then extracted, transformed, and loaded into ETL or ELT, extract, transform, and load, processes into a data warehouse or a data lake. From there, analytics tools like BI dashboards or AI/ML models consume the data to generate insights. Postgres often serves as the source system, the analytics database, or both. Big data tools handle the aggregation and processing in the middle. Understanding this pipeline end to end is essential for health informatics professionals because you will be involved in each stage, from ensuring data quality at the source to interpreting the analytics that come out the other end. Before we wrap it up, let me preview something that's coming next week. We mentioned that 80% of healthcare data is unstructured or semi-structured. Relational databases like Postgres are not designed for documents or graphs or key value lookups at massive scale. NoSQL databases fill that gap. Next week, we will explore 4 types. Document databases like MongoDB that store JSON, which naturally fits FHIR resources. We'll look at graph databases like Neo4 that model relationships between patients, providers, and medications, and key value stores like Redis for ultra-fast lookups, and column family stores like Cassandra for high-volume streaming data. Think of this as the natural next step in the evolution from relational databases to the broader data ecosystem. Let's summarize what we've covered today. Big data is defined by volume, velocity, and variety that exceed what traditional relational databases can handle. Healthcare is one of the largest producers of big data, generating massive amounts of structured and unstructured data from electronic health records, imaging, genomics, wearables, and even community sources. Big data tools complement rather than replace relational databases like Postgres. The key applications in healthcare include population health analytics and genomics and medical imaging and even the wearable monitoring. And now we're expanding into the social determinants of health integration. So, critically, your SQL skills transfer directly because most big data platforms support SQL. The talent gap in healthcare data, the need for professionals who understand both the clinical and technical sides, that is your opportunity as health informatics graduates.